Bismillahirrahmanirrahim. We'll start the workshop, and thanks for sticking till the end of the day and braving the long hours. Inshallah, hopefully it will be worth your time. My name is Haitham Al-Samawati. I'm a professor of radiology and the interim chairman at the University of Toledo Radiology Department. And I hope today to talk to you about ultrasound-guided breast interventions, give you some technical terms, and just before we start, can I get a show of hands who's doing women's imaging, ultrasound, mammography? Show of hands, raise your hand if you're doing that. And second, who is doing ultrasound-guided biopsies, drainage, seromas, interventions in the breast? So you have a few, mashallah. That's good. And who's interested in learning? So hopefully they will be able to start after the workshop doing that. So a lot of hands. So I'm hoping, inshallah, that I can give you some ideas, some technical curves. The idea here is to how to be safe, how to do the best procedure for your patient, and make sure that that patient is comfortable. Because I've seen and I've participated and helped train some of the radiologists in Alexandria, for example. And the main complaint that I used to hear from the patients is it's a very painful procedure and they never want to come back. I've never had that in the States. The patients are comfortable. They, ask at the end, "This is really it? We're done?" And I say, "Yeah, you're done. Procedure is finished and no problem." So we'll try to cover that stuff, give you some pearls and some technique areas that you really have to be careful about. So when you do the procedure, you're very safe, and that's the most important thing. So without further delay, we'll talk about pre-procedural consideration are very, very important. Again, patient comfort is number one. You have to have a safe approach to the target lesion that you'd like to sample in the breast. And your choice of the device that you're going to be using is very important as well. So you have to use the correct device to get the best results from that sample. This is how you get a successful ultrasound-guided breast intervention, whether it's biopsy, whether it's aspiration or drainage. So the topic outlined today, we're going to talk about positioning. It's very important. If you don't have a good position for your patients, you may actually start as already on the wrong track. So you want to start with a good position for your patient. Again, you're doing the procedure. You have to be comfortable in your position as well. So you can't be stretching and bending, and after you're done, you're basically having back pain and having issues, and you need to see a physical therapy person. So that would be a problem. You have to select the correct biopsy device. We're going to talk about anesthesia techniques. How can you really achieve satisfaction of the patients? Here you don't have this issue, but in the States, we get evaluated. The patient responds to a survey about did they have pain or they didn't have any significant problem with the procedure. And we get evaluated. And based on that, physicians get certain grades of how they are good and how they are not. And in the next few years, we think that there will be what we call the value-based payment. So if you're really doing procedures and your patient are complaining, you're probably not going to be paid as much as the next person who's doing the same procedures, who's actually getting much better surveys from the patient. So it's important. You don't have the system here, but still, just for the patient comfort, I think you have to have good anesthesia so you can actually get the best results while the patient's still not complaining, because they may need to have another procedure, and if they have a bad experience they will never come back again for another procedure. So we'll talk about anesthesia techniques and spade the needle position. It's very important. Nipple block, we discussed later in the section. We're going to go into details about these. We're going to talk about how to optimize the needle visualization in case if you're doing a wire rope or just a biopsy procedure. We'll talk about how you do fluid collection management, aspiration of symptomatic cysts. A lot of patients have cysts. Most of the time it's not symptomatic, but every once in a while you'll get a patient who's really complaining of pain, and the moment you aspirate that cyst, it's night and day. They are very happy and they thank you for the rest of their life. Also, drain placements after mastectomy. I usually get those referrals from my plastic surgeon because they get a lot of post-op seromas and they want to put implants and they want to correct and they want to do flaps, and those fluid collections are really a problem for them. So they ask us to drain these fluids first. So we're going to talk about that as well. So let's start with the positioning. Patient positioning is very crucial. Most of the time you're scanning the patient while they are in supine position, you find your lesions, your target area, and then you try to do your procedure. So usually if you have a medial lesion, a medial location, supine position is okay. The problem is when you have a lateral lesion. A lot of the time, if you're going to go after that lateral lesion and you're going to see a schematic cartoon that shows you the risk of that, you may want to actually put the patient oblique to the opposite side, meaning you lift that side up, a wedge, some towels, you put some, blanket or something, roll it, put it under their back, lift them up, let the breast fall on the chest to the opposite side. That will decrease the thickness of the breast, but also when you come with your needle, you're going to be parallel to the chest wall, and that is very crucial. So contralateral posterior oblique positioning for these lateral regions. It's a good approach, it's a tip. So everyone who's starting to do this, or if you're doing it already and you're just doing everybody supine, think about this and try it, and hopefully thank me later on, and just dua for me. If you do it and it works for you and it becomes much more of a practical thing for you, inshallah. For large breasted patients, a lot of times we have issues. And I know that there's a lot of females in Egypt with large breasts, and unfortunately some of the lesions are inferiorly located. It's those inferior located lesions that you're probably going to have to do something about. You tape the breast up. You have to tape it. If you tape it up and it stays up, then you can sterilize the area, then you can access without any problems. If you have to have an assistant, if the taping doesn't work, if you have to have an assistant, a nurse or a technician or somebody who can just pull that breast up and keep it up. Otherwise, you're going to really have problems, because every time that you're doing something, and you should be sterile, so if you're sterile, you're not going to be able to do anything with your hands, and therefore somebody else has to do that for you. If it keeps flopping back, you adjusted your position, adjusted everything, and the breast flopped down again, all that measurement that you did, all the planning is changed, and you're completely in a different location. So these are the things which are important about positioning. You have to choose your skin entry sites. You have to target, put your target in the middle of the screen with the ultrasound probe. We're going to see some hands-on examples, and we're going to do that together. And we have excellent radiologists who actually do this on a daily basis, will assist us as well, so we'll get all that. Every single one of you, hopefully by the end of the day, would be doing a biopsy, putting a wire, trying to see how you can put a clip in place after you do the biopsy, all these things. We're probably not going to be able to do the aspiration or drainage, but it's the same principle. If you master the technique for procedures, for biopsies and wire localizations, you'll be good at putting a catheter in. Usually you can do a 2 cm from the transducer edge, a dermatotomy, especially for lateral lesions. You may want to go more lateral to the placement of the probe itself. And we're going to look at a cartoon that will explain what I'm saying here. You might want to consider the cleavage line in the middle of the breast, in the middle of midline, if you have a medial lesion or a superior lesion. That's a good access point. The only thing is you have to put a lot of good numbing medicine in that area, a lot of lidocaine, because there is less thickness in that area and you're right in front of the bone. So if the patient is thick and has a lot of fat, that's okay, but a lot of patients are very thin in the midline, so the cleavage area you need to put quite a bit of lidocaine. If the target is deep, the distance should be greater. Take advantage of the chest wall curvature, oblique position. Again, this is very important. When it's deep and it's lateral, tilt them up. Move them to the opposite side, the breast will flop on the chest wall, and now when you come with your needle, it's going to be a shorter distance, and it's actually going to be parallel to the chest wall, and that is crucial. So here's one of the biopsy guns. If you're right-handed, it's always better to have a right-handed button. If you're left-handed, your left-handed button. I mean, it all depends on what equipment we have here. And I already discussed with the company, and it's BART, so you probably have some equipment similar to this that you should be comfortable with. So I know that some radiologists here and clinicians would actually ask for fine-needle aspiration. This is really not a standard of care. Standard of care is to do a core biopsy. You need adequate amount of breast tissue sample. The reason is it's not just to diagnose invasive ductal carcinoma or DCIS or lobular in situ, all the things that we discussed yesterday. It's actually much more important than that. The surgeons would like to know, and the radiation therapists would like to know, and the oncologists would like to know what is the status of PR, peritoneal, and KI67. So there's a lot of things that you have to run. Finding aspiration is not going to give you all that stuff. It will just tell you there's cancer or it's benign. It's not going to tell you everything else. So you really have to have a core biopsy. In my practice, I use a 14-gauge biopsy gun. For spring-loaded, so it just fires in 2 cm. I get a good 2 cm sample of the breast. I usually do between 3 and 5 biopsies, and I've never had a pathologist call me back and say, can we get more sample? This is not enough. Never happened. Usually it's adequate. So a core biopsy is very important. A vacuum-assisted device, same thing. It's easy. You just get in, you get multiple samples with a vacuum-assisted device. 3 to 5 usually is adequate enough. Again, it depends on the core. Moving off target a little bit, if I'm doing an MR-guided biopsy, our vacuum-assisted biopsy gun is like 9 gauge. It's much bigger even. And it gets quite a bit. One time I had a 5 millimeter lesion that I basically poured the whole thing. When they did the lumpectomy, there was no malignant cells. Everything was in the sample we got out. But that's a different story. So this is kind of the vacuum-assisted device that's spring-loaded. And what it does is, if you have the tumor right here, you fire the first one. I usually do it safely. It's a 2-step approach. So you do the first one first, which will fire the 2 cm. This area, the divot here, the tumor will be sitting inside of it right there, and then the second one will come out and will cut and will get this piece of tissue. Usually try to sample different areas so you get the superficial part, the middle part, the deep part, so you have a representation of the tumor. Because a lot of time you are dealing with an invasive component and inside the component adjacent to it as well. So if you sample multiple different areas within the same lesion, you are going to get the most representation of this lesion. And we'll show you these needles and show you how it works, hands-on, so you'll actually see what I mean when I say you fire the first one first, and basically it comes out, but it doesn't cut. The second, you adjust your position, you make sure that you're right in the lesion, and then you cut after that. You can do it all at once, but a lot of times, what happens is, when the needle hits the lesion, it actually deflects, and you're going right underneath it, in the fat, or right on top. It all depends. If you're doing usually that's a sign that I've found it very helpful. If it's a fibroadenoma, that's what usually happens to you. You just fire and it basically just moves because it's not fixed in place. It moves up or down and you're not sampling the fibroadenoma even. So the best thing is to go through it first with the first step and then the second one you will cut. So you actually know exactly where you're cutting. Anesthesia. Again, I can't stress this enough. I know that this is a complaint that I've faced in Alexandria from, the people who were doing the procedure. The females were complaining, about pain. I had to do one for one patient afterwards, and she couldn't believe it. I mean, she says, "Yeah, that wasn't anything. I didn't feel a thing. It's only burning sensation with the light pain, with the numbing medicine. After that, she shouldn't feel any sharp pain. That usually is enough." Here is really a very important cartoon that I would like you to really think about very hard. So here's your transducer probe, here's the breast, here's a lesion that we see with ultrasound. So if you're coming with your needle right here, what is the risk? If you're using a biopsy gun that will fire 2 cm, which is the one that I showed you, that Shiva, which I know that you don't have it here, but this is the one that I prefer to use. The 2 cm, what's going to happen? It's going to fire. If you're positioned here, your 2 cm is going to fire. You're going to cut the lesion, but you're also going to get a little bit of the pectoralis. If you're lucky, you're going to hit the rib cage. The patient is going to complain. This is very painful. The periosteum on the ribs is very sensitive. You will have a complaint from the patient, significant complaint. So that's also not a good thing. But if you're unlucky, you're actually going to get in the middle. And this is where you're going to end up with a pneumothorax. You're going to get into the chest, you're going to get into the lung, you're going to puncture the pleural space on the lung, and you're going to end up with a pneumothorax. So the people who have been doing breast biopsies, any one of you got pneumothorax before? None. You guys are lucky. I did have one, but it was not actually on a core biopsy. In 20 years, it was actually on a fine needle aspiration in the axilla for a lymph node, which was very small, and was actually right against the bone. And that was an error. So that definitely can happen. So you want to be careful. You don't want to be firing when you don't have 2 cm that you can go through of breast tissue. If you're not having your 2 cm, that means that you're using the wrong needle. If you need only, if it's a lesion is small, use 1 cm needle. Get the correct biopsy device. Otherwise, you're going to end up with a problem. The other thing is, what you can do for these is what we said: positioning of the patient, make yourself parallel to the chest wall, and instead of coming like right here, 2 cm dermatotomy side away from your transducer, and now you're coming more perpendicular to the transducer. Again, your transducer is sagittal, you have to see the entire length of the needle. You're not seeing the entire length, meaning that you see part of it, it's going this way. And therefore, you can see part of it, but then your tip is going to be somewhere else that you don't know where it is. It can be in the chest wall and it can be in the lung. That's a problem as well. So if you go lateral a little bit, and you move your dermatotomy side 2 cm, what you're going to do is, when you fire, when you position yourself, I'll show you here. I'll just use this mouse. So if you're positioned right here, you measure your 2 cm and it's still outside the chest, outside the rib cage, you're safe, then you can fire, and then you can sample the lesion safely without getting into the lung. So you have to see the entire length of your needle in your plane of imaging, and you have to measure every single time, and we'll see some examples of that. Adequate anesthesia. I mentioned that before. You have to have adequate amount of anesthesia for the patient to be comfortable. So you have to inject your lidocaine. Usually you'd like to, the area that you're coming in with the needle, so proximal to the lesion, above the lesion, below the lesion. And if you're going to use a vacuum-assisted device, my experience with these is very painful. They are much sharper than the spring-loaded biopsy guns. Meaning that if you're going to go through the lesion to core it and get your sample, they will complain when you hit the backside of the lesion. If that's the case, you actually need to put lidocaine on the opposite side. And that you're going to have to do if you're probing this way and you're coming and you're sampling the lesion. You're going to come from this area, so you're going to give lidocaine before the lesion, lidocaine above the lesion, lidocaine below the lesion. You can't go across and get to the opposite side. What you have to do is your probe's still here. You come from the opposite side of the probe with the needle and you put your lidocaine in the opposite side. The reason for that is you never want to do this. Okay? You never want to go through the lesion to put lidocaine in the opposite side. The reason for that is theoretical, but it's still a risk. So here's again what you should do. You should do above, before, and underneath, and then come from the opposite side and do your injection. You don't want to go through it because there is a theoretical risk. Tumor cells are going to be cored by your needle, despite usually we use a 25 gauge for numbing medicine. It's very, very small and it's usually not that painful. But if you're still going to go through the whole entire lesion, that needle track is getting cells all the way in within the needle itself. And then when you're pushing your lidocaine, you're pushing all those cored cells into the surrounding tissue. So if it was just one lesion, now you're making it multiple satellites. Most of the time these cells will not survive without blood supply, but theoretically they can. So why take the chance? Just come from the opposite side and you'll be safe. Usually it's less common with the vacuum-assisted device, but with a core needle biopsy that can happen as well. So again, very important to remember, come from the opposite side as we discussed, and put your lidocaine if you're going to have a vacuum-assisted device. Again, those are usually the much more painful. I mean, if you're using a core biopsy gun and when you go through the lesion to the opposite side of the lesion and the patient complains, that means that that biopsy gun is sharp as well. So, you still have to do the numbing on the opposite side. If that's your practice, if your needle's here does that, do the same technique like we discussed. My experience, I've never had anybody complain when I go through the entire lesion with a core biopsy gun with those Achieva that we're using. They only complain when it's a vacuum-assisted device, the device we're using, and therefore I definitely do put lidocaine on the opposite side for these patients. And they never complained after that. What about a nipple block? If you have a retroareolar lesion, every once in a while you find a mass which is right behind the nipple and areola, you need to do a nipple block. You need to numb that whole area. If you have a topical anesthetic, even those freezing sprays that sports medicine people use, just spray that area or put a patch or something on the nipple and areola. That's kind of a topical anesthetic. Then you do intradermal anesthetic at the areolar margin, and then you do the periareolar subcutaneous anesthesia, and then you can do your ultrasound guided biopsy. What we mean by you can use the topical anesthetic and 1% lidocaine. And how can you do this? Here's a schematic representation of that. So here's your lesion. You can start with this area and kind of numb. You see this is always 25 gauge needle. It's very small. I tell the patients, just a poke and a burn. This is what you're going to feel. It's almost like when you go to the dentist and get a shot of Novocaine. It will burn and sting, and it should go away shortly. That's what usually happens. They feel the poke, they feel a little bit of burning, and then after that it goes away. And you just numb the whole area around. So either you do this curvature here and you keep going around the opposite side, or you can do linear. So you can do a line. You numb all the way from here to here. You come back again from the tip here. You direct your needle again to the opposite side. You numb all the way from here to here, and then you come from the opposite side and numb all the way from here and numb all the way from here. So this is kind of a nipple plug. Mouse doesn't show. Sorry about that. And it seems like we're running out of, okay, hopefully this one is not going to die. So this is what I'm talking about. It goes from here to here. Thanks for this, appreciate it. So you go with the needle and you numb all the way from here to here. We have another pointer, please, on the back side, because this one is dying as well. So from here to here, or you come and do the linear on the opposite side. And this one died as well. So you just come with the needle from the one side and you just basically go up and you go down and you kind of numb the area in linear pattern on both sides this way, and then you come from the opposite side this way as well. Well, it's the end of the conference, so the battery is pretty much gone. So I apologize for that, but hopefully they will fix it. So yeah, it starts and then goes away. If you have a battery, that would be nice. Thank you. So, as we discussed, the other thing that we need to do is, if you have a superficial lesion, and you're going to biopsy that lesion with a core biopsy, again, I'm not talking about the fine needle is simple and easy, but really the standard of care is to use core biopsy guns, and when you're going to use a core biopsy in a superficial lesion, there are risks. So why we're giving a lot of lidocaine on top? We have to have that space become bigger, and that's become very helpful, because you don't want to have this scenario happening. You don't want to have your biopsy gun over here, take a sample of this lesion, and then the fibrosis and scarring end up denting that breast and causing significant scarring and dimpling in the skin. But what you need to do for those superficial lesions is put a lot of lidocaine, separate the dermis, separate the skin and the subcutaneous fat from where the lesion is. And then you can sample successfully and you don't end up with any complications. So again, another pearl, another trick. Hopefully if you just take those few pearls that I'm telling you today and keep them in the back of your mind, when you face a case like this in your practice, hopefully you'll apply it. Here's a case scenario, a lesion that's very superficial, very close to the skin, definitely concerning. There was another lesion here as well. That mouse is not even showing. You guys are right. Do you have new batteries? Okay, so here it is. I'm sorry. Here is the lesion, which is very superficial. Here's another one that is deeper. So in a mammogram, we saw this lesion, and basically we did the ultrasound. One of them was pretty benign characteristics, looks like a fibroadenoma, which was the the deep lesion, but the superficial lesion looked somewhat concerning. There were some edges which are not well defined, and in ultrasound, it basically has a little bit of irregular borders in some of the images, has some mild angular margins, so it was somewhat concerning, and therefore we decided we need to sample that one. So here what we do is, you can see the lidocaine is being deployed right under the skin, separating this lesion from the surface. Here's another image of that lesion, and the color flow showing that it does have, color flow, and it is bilobed, and it kind of has some irregularity in the margin, so definitely concerning. And after we measured it, figured out that this is pretty much a 1 cm lesion, so you really need to pick up your needle that you will use for that. And then we came in with a biopsy gun and we sampled. So the important point here is after you deposit a lot of lidocaine, now you see the separation. That lesion was very close to the skin. Now we separated it from the skin. You put about 3 or 4 ml of lidocaine in that area, just superficial. You push that lesion down, separating it from the skin and subcutaneous tissue. And then you put your needle, and you, again, can't stress this enough. You have to see, as long as your probe is sagittal and your needle is in the middle of the probe, you should be able to see the entire length of your needle. If you're not seeing the entire length, you're not perpendicular. If you're doing this and this, that's not a good approach, because when you fire at 2 cm, you can't see where your end of the needle is going to be. And that can be a problem. So you stop before the lesion, you measure your 2 cm, or definitely away from the chest wall, so it's safe to fire. When you are done with that, then you can fire and you can sample. Here's a pass 1, pass 2, and you can see here's what I say about you get your first pass in, your first needle goes through, and then the second one comes on top of that and cuts within the lesion. And here is the lower part, pass 3. So we're going superficial, mid, and deep, and we get those 3, and then we put our post-biopsy clip as we're going to see. So you can put your biopsy clip here. This one was kind of at the edge of the lesion. Switching gears quickly to wire localization. If you have microcalcifications, you're not going to see those by ultrasound. You're going to have to do wire locks based on, you're going to do stereotactic biopsy first. This is the stereotactic gun, getting a sample. You get a specimen ready graph. You confirm that you got your microcalcifications in the field. And then you place your biopsy clip and you confirm with mammogram where the clip is. This turned out to be DCIS, so now the surgeon is asking us to do a wire lock so that they can resect and do a lumpectomy of this lesion. So we put our grid, we localize where it is, we put our needle on the CC projection, for example, localizing it exactly where we want it to be, so that's like, G and probably 5, and then you can position it, and then you adjust your position on the lateral view. This was actually done from below, which is a little bit uncomfortable, but sometimes you have to do that because it's an inferior lesion, and you have the biopsy clip right where the wire is as well. Then the surgeons will take the lumpectomy, and they will usually come down after they take the lumpectomy with the specimen to check and make sure they got the area of concern. So what we do here is a specimen ready graph, which will actually show the clip, shows the hook of the wire right at the center of the specimen, and you're probably not going to see the microcalcification right beside this area, whatever is left of that DCIS. So you can do the wire loops with mammography stereotactic technique, with mammography guided technique. For microcalcification, you'll have to use that technique. But if you have a lesion, you'll have to use ultrasound for the wire loops. It's much easier, much more comfortable, less risky. The patient is not standing in a mammogram, and all of a sudden, when you put your wire, she doesn't have a vasovagal reaction, and she falls, and the needle is there, and you have a disaster happening. So if you can do it with ultrasound, it's always better. Here is another patient that definitely shows a lesion that looks suspicious in the CC projection compared to the opposite side. And again, definitely concerning lesion in the MLO view. Very small, but when we did the spot compression views, we actually found there's 2 of them, but one of them is the concerning one. You can see the spot compression view. This one is definitely irregular, looks like a malignancy. The other one looks more well-defined. Could be a small satellite lesion, but definitely is not that suspicious. So the ultrasound exam of this patient at 6 o'clock position, you find this irregular, taller than wide, posterior acoustic shadowing, has color flow. The color flow is very important because you always, when you're going to fire your biopsy gun, you try to avoid the big vessels in the lesion as well. That helps you. So right before I fire,